big. Okay.
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 I was able to.
So,
okay.
So can you guys hear me now?
Yes, we can hear you. So just go ahead and share.
I somehow cannot. And you, okay, share my screen, right? Hold on. Somehow I'm not sure. Why am I not sharing the screen? Okay. You think in 2 years I would be able to figure this out, but it's just the system is so slow today. And I think it's because of the, I'm at PIH, so sometimes PIH blocks everything from getting access to your Google and everything. But
Dr. Ganguly, Nancy, it just gives us an opportunity to say thank you. Happy Doctor's Day, and we are so grateful for
you're welcome.
All the training, all the guidance you give us, and needless to say, all that you do for the greater community. Thank you.
You're welcome. Now, I wish I can, somehow I don't even see you guys, but I know I'm seeing Alice's face somewhere, so I don't know where that is. This is just embarrassing in a way, but we will start off anyway. Let me see if I can read.
I think he got logged out.
I think he was to try to reboot and sign in again.
Sharika, you have to.
Okay, I'm going to make you the host again.
Yeah, please. Let's see if we can do it.
Okay, go ahead.
Share. Okay. So let me do into the mode of presentation. Okay. After trying for 23 minutes, we are here. So we are talking about acute ischemic stroke and the outline of this talk. Can you guys hear me now?
Yes, we can hear it and see it.
Yes,
okay,
we can.
Good. So the outline of this talk we'll talk about some basics. We'll do a case discussion, which will eventually lead to what has happened in stroke care in the last 25 years. We'll talk about a new kid on the block, and most likely we will get to that in maybe a month or a year. And then we'll talk about thinking out of the box and the future. So we start off the basic question that is time lost really brain loss? And if you go by the studies that they have done, they say that around 1.9 million neurons are dying every minute, which is equal to 4 billion synapses and around 7.5 miles of myelinated fibers. So in other words, if you say, well, what does that mean? That means that when people are having an acute stroke, they lose about 4 years, 3.6 to 4 years each hour. Oh, you can't see me anymore. What is happening?
We can see it, Dr. We can see it, Dr. Ganguly. We have no problem. I don't know.
You can see what I'm showing, right?
Yes, I can see slides right now.
That's all it matters. Don't worry about it. I
Yes.
didn't change. I didn't change in the last 7 days, so it's the same. So don't worry about it.
Okay.
So the main thing is that let's see. It's okay. So it comes down to that we almost lose like 3.6 to 4 years every hour when someone is having a major stroke. So if someone is like 40 years old and they're having a big stroke, in a matter of 6 hours, 6 times 4 is 24. They're becoming 64-year-old, like in just 6 hours. So it's important that we try to get or reduce the disability as fast as possible, because otherwise this person is disabled for life. So regarding the pathogenesis, we know that 80% of the strokes are related to ischemic strokes, of which 25% is lacunar, 25% is cardioembolic, which is mostly atrial fibrillation, and there are some types of and some of them, most of them are atherosclerotic, which is 40 to 50% in our society or in the clientele that we deal with, because most of them has high blood pressure, diabetes, and hyperlipidemia. And then there's 25% which are like cryptogenic. We don't know the source, and we previously we used to call them cryptogenic. Now we call them ESUS, or embolic source of unknown etiology. So, and hemorrhagic stroke, we won't be talking about the hemorrhagic stroke today because it's 20%, and we'll talk in a separate time frame. So we start with a case. Miss Jones is a 78-year-old with a history of hypertension, diabetes, hyperlipidemia, and history of ovarian cancer. Status post resection of the cancer, in remission. Started having some slurring of speech and right-sided weakness while having breakfast at 9 o'clock. So this is the patient, although lives near Whittier Hospital, but came to our hospital. But this is the thing that you have to know, that what we do as a stroke team or a stroke activation, that we generally, within the last well-known time, and if someone's having a disabling or any type of deficit within the last 4.5 hours, we call it a stroke 1. And between 4.5 hours to 24 hours, we call it stroke 2. Now, the last time when we had the surveyor actually did not want us to do the 4.5 hours. They said anything within the last 24 hours, you should go for core stroke 1, which I had to explain that within 4.5 hours, the importance is that it needs the thrombolytics to be on board as fast as possible, but she was not very keen in knowing that. So what are the common mimics? For the commonest mimic you have to, that's the reason you have it in the stroke, in your stroke ordosis, is glucose, because hypoglycemia can cause stroke-like symptoms. But once you correct the glucose, and if the person still has a problem, then it's not the glucose anymore, it's the person is having a stroke. What about your postictal state? Like if someone has a seizure and then they are having weakness of one side, that's called TOTS paralysis. Then there is always a subarachnoid hemorrhage, but that should be in the history that they had a massive hemorrhage, or that massive headache, or the CT should show subarachnoid hemorrhage. Migraines can present like this, but not that elderly person. You don't expect migraine. Mass lesions can present like this because you have a person who had a history of tumor. It's a possibility. And hypertensive encephalopathy, although is possible, but less likely present with focal weakness. And conversion reaction is, no one wants to go nowadays to ER with conversion reaction because of COVID. So this is the CT scan, and many people have seen this CT scan over the years. And this white thing is the skull. These are the eyes, and this is part of the nose that they can check. And anything white, we say, if there's a white inside this white rim, then it's mostly a bleeding or a fat or calcium. We don't see any white, so we know it's not a bleed, but we see something here, which we'll talk about later, is like a white, almost like a rope going in here. And we'll talk about what that is. So this is what exactly is happening with the patient, and that white rope is that this is the clot, and this artery, as you can see, is blocked here. There's no flow in this freeway. There's a little trickle flow here. So this is the normal color of the brain, our brain baseline, our brain architecture. So this white area is already, because there's no flow, this white area has been dead, or it's not receiving blood. It's receiving blood less than 15 ml per hour, which is should be around 30 to 50 cc's an hour. On the other hand, but between the normal tissue and this abnormal tissue, you can see also there's a lot of this dark gray or black area, which is actually the area which is about to die if this clot is not dissolved. So this is what we deal with. This is the area that we are going for to preserve, because between this much of stroke and this much of stroke, you're talking about a person being out in the back to the society versus person being in a nursing home. So all of us in this lecture knows that FDA has approved this medication called a TPA, which is only for ischemic stroke. It is all the studies as well as all the societies have told us that you can use it till 4.5 hours. Now, TPA is like driving a car. You know, you get to learn to drive the car and you have to handle it with care. So that's the reason we have to have strict selection criteria for the TPA, because it's not like, oh, give another dose of vitamin B12, because that's what it came as a clot buster, where you can see this clot sitting here, and that's where the TPA works and it tries to break the clot. Now there's a video in here, but I don't think the video will work, but I can try it anyway, because what's there to lose, right? And it doesn't look like it's working. So we will move forward with it. This is the famous study with the TPA, where you can see that people got placebo versus TPA. And in 3 months, there were two parts of the study. One is within the first 24 hours. Did people improve? The answer was no, people did not improve in the first 24 hours. But when patients, some of them improved, but not to the one that the study was positive. But when patients got TPA, in 3 months from the time they got TPA, the risk of disability was significantly low.
I'm listening
The
to him.
risk of being,
If that's the case, I'm gonna watch something and not just.
No, honey. I'm listening to him. Okay, Brady, stop.
okay. Okay, I think I'm hearing a lot of noise or chatter, I should say. So if you can just mute your button or that microphone, that would be nice. So so in people with placebo versus people who got TPA, the risk of disability was significantly less in 3 months from the study. So when we discuss about this thrombolytics, we always used to say, oh, it will get better. No, it's something's coming up. Yes, okay. So that's where we always tell patients that it does not matter what will happen tomorrow, but over the time, your chances of going back to normalcy is better than a person who is not getting TPA. Okay, and oops. Let me take that off. So this is the Swimmer's NINDS style, and you can see people who got TPA, even between TPA and placebo, the people with TPA did much better than people with placebo. But there is a time frame, and the time frame is this 4.5 hours.
I can't hear anything. He's frozen. Because it
I
says
think, when is the last time you guys heard it? Charlene,
graph.
can you unmute and tell me the graph? Okay. Can you see the graph or no?
Your screen just went away, Dr. Ganguly.
We cannot see anything right now, Dr. Ganguly.
You just
Roxanne.
saw the graph, it just went away.
Roxanne, you
Okay.
got to mute yourself, you guys.
Okay. Is that, can you see it now?
Yeah.
Yes.
Okay. So, the graph, the previous graph or this graph? Let me go to the previous graph. Hold on. Let's go back. Okay. So this was this famous, again, it says internet connection is unstable. I mean, you have a $1 billion hospital, but somehow the internet is unstable. So this is the NINDS TPA trial, which shows that people who got TPA did better in all scales, Rankin, Glasgow, NIH. They did much better than placebo in 3 months. And that's where the FDA approved this medication. But there is a caveat to it that we have to do it within the first 4.5 hours. The earlier you use TPA, the chance of reducing the disability and getting back to normalcy is higher. So that's the reason we don't want to delay the TPA till whether the patients are getting better or not. You just do the TPA as fast as possible. And also, if you do the TPA fast as possible, the chance of harming that patient is much less the earlier you do it, because less brain tissue is being damaged, so the risk of bleeding in that brain tissue is less. And you can see this is earlier is safer. The earlier you do it, within 90 minutes, the risk of complication is 9.6, whereas if you wait for around another 90 minutes, it doubles up to 11.7. So that's on the basis of that, TPA has been approved by FDA, but you have to do it. The faster you do it, the better. And remember, now we have within 45 minutes is the cutoff time, that from the time they present to the ER to the time they get the TPA. We want it to be done within 45 minutes. That's what they monitor. But worst case scenario within 60 minutes. But in the next few months, they will be coming down to 35 minutes. So they are just pushing the TPA. The faster you do it, the better. What about the numbers? The number need to treat for to get back to normal is somewhere around 8, but it's improved for 3.1. And out of the 100 people, 3 will be harmed. So when I discuss about TPA, this is what I tell them. 30% of the people will get back to normal after this medication. 30% will have a significant improvement to the point that they won't be disabled and they'll be back without disability. And the last 30%, the TPA wouldn't work, because those are the large clots, and we will show you examples. For those, we need endovascular therapy along with the TPA. But out of 100 people, there will be bleeding in 6 patients, and of which 3 will have a devastating bleeding, which is, we call it symptomatic hemorrhage. So people who want to know how TPA works, this is the graph, but it generally binds with the fibrin to the fibrin clot, which again traps and converts the trapped plasminogen to plasmin, and then initiates the fibrinolysis, and then it causes the proteolysis. So this is what it happens. And every one of us has TPA. By the time, longer time you guys have been waiting to have this conference, I'm sure there are small clots which has formed in the legs, but your own body is in a position to make the TPA and break the clot. So that's how it happens. And then the coagulation factors leads to fibrinogen, then leads to fibrin and makes the clot. And that's what the TPA comes in, makes plasminogen to plasmin and breaks down the clot. Remember, TPA 50% is cleared within the first 5 minutes and 80% is cleared in the next 10 minutes, but the effect remains for the whole 24 hours. In people with renal failure, that's a little bit delayed than what I'm showing you. So the inclusion criteria for TPA includes onset of symptoms less than 3 hours, or if greater than 3 hours, but less than 4.5 hours. There are some criteria now which has been used, which we will talk later, of wake-up stroke protocol and everything. Must have a reviewed CT scan of the brain, which should be negative for bleeds. Labs should be reviewed, mostly with PT-PTT, INR, as well as sometimes we do also CBC. And definitely clinical diagnosis of stroke with a measurable deficit. So someone has a tingling of the face. Well, is that sufficient enough to get TPA? The answer may be no. But on the other hand, someone cannot talk, cannot see. That's where that's a disabling deficit. And they say 18 years of age or older, but now we have studies which are younger than 18 years. They're doing studies with TPA, and actually the studies are turning out to be good. What about the exclusion criteria? Definitely you can't have ICH or cerebral bleed in the CT scan. There's no active internal bleed. If there's a thunderclap headache, which worst headache of someone's life, and they passed out from it, and then they are having some symptoms, you always have to worry about subarachnoid hemorrhage. If they have intracranial surgery in the last 3 months, any history of ICH or AVM. However, aneurysm, if it is less than 10 millimeters inside, it's safe to get TPA. It's not a contraindication. And if the BPs cannot be controlled, then persistently, and that's where the nicardipine drip comes into play. If the systolic is greater than 185 and diastolic is greater than 110, then we cannot start the TPA. Glucose less than 40, less than 50, we talked about it. Platelet count less than 100,000. On heparin with an INR or a coumadin with an INR of 1.7. But if they're on low molecular weight heparin for prophylaxis for DVT, that's fine. That's safe to do it. Oops, sorry. The protocol is 0.9 milligrams per kilogram. 10% of the dose is in bolus, the remainder in an hour. And no anticoagulants or antiplatelets for TPA within the next 24 hours. We observe the person in the ICU with a systolic blood pressure of 180 and diastolic of 105 and below. And we try to avoid arterial puncture. putting in an NG tube. You know, there was a patient in our ICU where there was a GI bleed, and then we put NG tube, and that caused more trauma to the patient. But it was, it was reasonable. We needed to do it, but it wasn't. Sometimes I want to avoid those. And we all know that during and after, 15 minutes for the first 2 hours, then 30 minutes for the next hour, for the next 16 hours, we do it. And we always target that blood pressure of 185 and below, and the diastolic of 110 below. And you can use labetalol, hydralazine, nicardipine, whatever people are comfortable with, fine with us. What about consent? Generally, within the first 3 hours, you don't need a consent. Even with the first 4.5 hours, nowadays you don't need consent, because many patients with stroke can come with aphasia, and they can't give you consent because they're aphasic. But you have to do the best for your patient, that if the person was not aphasic and the person came in the first 4.5 hours, they would be in a position to tell me that, yes, give me that medication so that I can go back and talk. The thrombectomy, even in thrombectomy eligible patients, we start the TPA first before we run for the CTA and everything. But if the NIH stroke score is low, is there a rationale for giving TPA? Then, and that's where it comes down to, we don't always follow up these patients, but 30% of these patients end up with disabling deficit. So although this was a little bit, weak and numb and heavy on one side, the next day, they're completely hemiplegic. And that's the reason small deficits are not small. You have to treat every deficit as if, because after 4.5 hours, you don't have a chance. What happens if someone's having a TPA and then they say, oh, I have a mild headache? You can, with no neurological change, or there's a severe bad headache, or a headache with a neurological change. All of these, immediately we should stop the TPA and repeat the CT scan. And if they're negative for any bleed, then they can go ahead and finish the TPA. If it's positive, then we go into the ICH protocol. So post-TPA headaches always a concern for hemorrhagic complication. Stop the IV TPA, repeat the head CT, and if no hemorrhage, continue on IV TPA. But there are some reports with after TPA patients can get headaches, and part of the reason is that TPA sometimes vasodilates and opens up the arteries, so sometimes people will have headaches. This is another concern, which is an angioedema. And you can see that half of the tongue is pushing the other side, and people get into striders, and you have to stop the TPA, give the steroids, and sometimes we need to tube the patients. And then you add the H1, H2 blocker. This is a new kid on the block, tenecteplase. A similar mechanism. It's a longer half-life. You saw TPA's half-life was 5 minutes. This is 20 to 24 minutes. It has 14% greater fibrin specificity, and it's 80% high resistance to TPA. To plasminogen activator. So it's a more specific molecule, and it's much easier to give because it's just a shot. Like it's in a minute, this is done. So the cost is also lower. This is a bolus, and it works definitely faster because that's what TPA, you have to wait for a whole hour for the TPA to go in. And there are studies which people have large vessel occlusion, TNK works better than TPA, but we are not there yet to really compare that. They did a meta-analysis between these two, and TNK was non-inferior to TPA. So this is something which eventually Beverly may use it, but we will talk about it in the near future if people are all comfortable with it. And there are some studies which are coming out mostly with pregnancy as well as wake-up strokes that we'll find out what the results of TNK on those are. And if they all come out to be okay, then most likely we'll head towards this because the door to needle time will be much better with TNK. So that's that. On the basis of that, they gave us, FDA gave us the permission to use TNK. There are actually a cardiac dose, and there is a 0.4 milligrams per kilogram, and there's a 0.25 milligrams per kilogram. Most of the hospitals use 0.25 milligrams per kilogram, and most of the systems have all changed, like UCLA, Cedars, PIH. Everyone has changed their things to TNK. So on this patient who came in, and she got the TPA, and now after the TPA is over, now her NINDS score is 26. She got much worse. We did a repeat CT, and there was no bleed, but the repeat CT showed that what I showed you, which was this clot. So as we talked about, that 1/3 of the patients with TPA would not benefit is because they have a clot like this big. And this big of clot, if TPA, even if you do the whole pharmacy of TPA, they won't dissolve this. So along with TPA, we need mechanical thrombectomy. In 2015, there were these, the multiple papers on this same thing, and all of them showed that if you do mechanical thrombectomy along with TPA, the outcome is significantly better in these patients. And these are the different studies: Mr. Clean, Escape, Extend 1A, Swift Prime, Revascat, and then they all achieved a great outcome with Tiki 2B3 as well as Escape. A lot, but remember, all of them had TPA on board. So this was the guideline, which was a pre-MRS stroke score of 0 to 1, or patients received the IV TPA within 4.5 hours. As long as the NI stroke score is greater than 6 and the aspect score is greater than 6, and the symptoms happened within the last 6 hours, that's how we used to do it. So there was limited information beyond 6 hours in 2015. But then, and how do we do it? We engage the clot, retrieve the clot, and then get the clot out. And this is I don't know whether it will work, but let's see if this works. So you can see this is the solitaire device, and this is what they put it. I think there is a little video of it. So now they engage it. Now they will open up the, let's see if they, yeah, now the solitaire is opened up, and now you can see that the clot is trapped, and this is from the inside, how it looks. And now they close the proximal part of the carotid, and now they suction the whole clot out. And after they do that, they open up and you can see this is a negative suction. So things, although can go further down the stream, but then eventually, and now they have done an angiogram, and you can see that the whole thing is open up. Okay, let's see if that goes. Oops, sorry. Okay. This is the same thing, so I will just cross over. So this is a patient who's an 85-year-old who had a cabbage 4 days ago. But then you can see that patient all of a sudden developed some weakness involving the right side. And they did a first angiogram. You can see the clot sitting here. You can't see the artery. So they went in and did the embolectomy. They got this clot out, and now you can see the whole arteries have recanalized. So yes, mechanical thrombectomy, we have gotten significantly better. And there are different devices now we have, like a coil retriever, a stent retriever, a cover stent, a basket retriever, a brush retriever, you name it, aspiration catheter. And also, depending on what type of clot you're dealing with, sometimes it's a clot is from atrial fibrillation. So those are different clots than clot from an atherosclerosis. From a carotid artery, if there's a clot that's more rich with platelets and lipids, whereas a atrial fibrillation clot is more a red clot, whereas the carotid thing is what is a white clot, which is more with fibrin and platelets and stuff. So there's different ways and different type of aspiration devices. So aspiration devices work more for a clot, which is a carotid clot, whereas the atrial fibrillation clot works more with a stent retriever. So they have different ways to gauge this, and it is a work in progress. So this is the current thrombectomy protocol or indications. that generally beyond 6 hours, if there's an occlusion in the M1 or M2 or in vertebral or basilar, then we give the TPA and then we bring them on with the thrombectomy. However, what happens to this patient? This is a patient who is 58 years old with hypertension, diabetes, hyperlipidemia, shortness of breath, was doing well till around 7:30 a.m. The CNA finds the patient non-responsive. Patient went to bed around midnight. When he interacted with the nurse and took his pills, patient's nurse came to evaluate and called in a acute stroke. So the last well-known time, this person is being found at 7:30 a.m. to be having these symptoms. So the last well-known time is the night before. So these are the vitals. You can see there's an irregular pulse going on. Blood pressure is higher on the higher side. Patient cannot respond. Gaze deviated to the left. Right facial weakness, spontaneously moving the left side, but not the right side. And glucose check of 106 with the labs in PT, PDT, INR, and CVC normal. So that's where all this wake-up stroke or the thrombectomy between 6 to 24 hours after stroke came into play. There are two studies which we did. One is the diffuse, the other one was dawn. And we saw that if we selected patients, depending on the imaging studies, there's a significant benefit on these patients, in spite of the fact that the stroke happened, more than 6 hours ago. So this is the patient that we talked about. And this is actually a Beverly patient who was transferred to PIH. As you can see, this is the first CT scan, which is the non-contrast CT scan. It shows that there is some hypodensity in this area already happening, which you don't see on this side. And if you put the color, the color flow, you can see that this whole area is being hypoperfused. But if you look at the blood volume, you can see this is still salvageable. This is all infarcted. So amongst all this area is infarcted, but the rest is salvageable. So this patient, as you could see, they had a CTA, and this is exactly where it is, the clot is. And the reason that patient is doing better is because she has collaterals coming from the outside. So they opened this up, as you can see, this was the stump, and now they opened it up all together. And this is the MRI, which showed exactly what happened with the CT, what you're seeing in the color perfusion. So that's where we are. So that's the reason that the surveyor told us that you should do it within 24 hours. So what's new since the last 2019 guidelines? There is a new thing called wake-up stroke with TPA. So if the person comes in, like this person came in dizziness, slurring of speech, and left hemiparesis at 5:30 a.m. Last well-known time was the night he went to bed. His NI stroke score was 5, and his vitals were a little bit elevated. So this is the person we had a CT negative, CTA negative, labs negative. So the question was, this is a person of TPA or not? So a week before this person came in, we had this paper in thrombolysis guided perfusion up to 9 hours. And those people did bit better with TPA than people who did not get it. So on the basis of that, AHA already recommended this, that this can be done if there's a diffusion perfusion mismatch in the MRI, and that's what we did on this patient. This patient came in around 7:30 in the morning, I still remember, and Tom was working during that time. Tom was driving in, so I got him on the scanner, and you can see that the diffusion is positive, but there was no flare change in the still within the 3 hours. And you can see in 24 hours, we gave the patient TPA, and this is what happened with the area of the stroke. And this was a minimal flare, so we could save a lot of the tissue around that area of the stroke. So that's the reason that we don't give up in patients who came in with wake-up strokes. We want to, if there's a significant disability, we want to push that MRI. We want to get to see if we can help that patient if the patient is not a candidate for thrombectomy. What about non-disabling strokes? They say that if you give it within 0 to 4, and if it's non-disabling, then it's no benefit. But remember, our friend or an ophthalmologist who started having some numbness in the right hand around 9 o'clock the night before as he was petting his cat. Ophthalmologists can only do that, not neurologists. They get, that's a pretty good life. He came to the ER he was persistent. He was having his symptoms. His NIST score was only 1, and his CT was negative for anything, acute. And so he came in the window of thrombolytics, and the question was, his symptoms are so mild. But the problem is an ophthalmologist. So if you go to a surgeon, an ophthalmologist, and they don't feel the right hand, and they're doing a surgery, let me see who will sign up to have their eye cut for that person, right? So it's a disabling deficit. So he understood that, and he wanted to get the TPA. The question was was it something, like a carpal tunnel? Well, why would a carpal tunnel start all over at 9 o'clock, right? The carpal tunnel happens when you wake up in the morning and you shake your hands and stuff. So that's a little bit off. So immediately, we knew that there was something wrong. And well, this is it. So you can see the diffusion positive. So this is your sensory cortex. And there was a big clot which actually broke into few small clots. And that is also present in the ADC. So that's immediately told you that the person had a stroke. So bottom line is disability, like beauty is in the eye of the beholder. Disability is in the eye of the patient who is suffering from disability. So that's, having said that, I'm sorry for the rough tour and a fast one, but if there's any questions, I'm happy to answer any questions. I did so fast that people were like, okay, he can't finish it by 3.
Thank you, Dr. Ganguly.
Yeah, but I've been in this rodeo for a long time, so never underestimate. I can talk fast and furious and sometimes deliriously, but I still will finish it because time is brain, I know. I don't want to waste people's time. So there will be a questionnaire after this. I already sent in another questionnaire to Charlene, and you guys should be doing the questionnaire. And and then you have to score 70%. So good luck.
Thank you.
Okay.
Anybody has questions? If not,
We are
I
done.
think, yeah. Thank you, Dr. Ganguly. Thanks.
Bye.
Bye.